This video abstract will discuss the paper Characteristics of SARS-CoV-2 Aerosols Dispersed During Non-Invasive Respiratory Support of Patients with COVID-19 by Ramsey and others from the January 2023 issue of Respiratory Care. Previous studies have identified SARS-CoV-2 in air samples taken from hospital rooms of subjects with COVID-19. Early in the pandemic, invasive ventilation was preferred over non-invasive support, such as high-flow nasal cannula or non-invasive ventilation, as it was thought to help control the spread of infectious aerosols. The aim of this study was to characterize aerosol dispersion in subjects with COVID-19 receiving non-invasive respiratory support therapies. The study included adults who were hospitalized with a positive PCR for SARS-CoV-2. A saliva test was done at the time of aerosol sampling to confirm viral shedding. Air samples were collected from the hospital room using a personal air sampling device that was placed 30 to 45 centimeters in front of the subject at chest level and a portable sampling unit placed 2 to 3 meters away from the bed. A scavenger mask was used to contain and direct sampling in close proximity to the subject. Filters were collected from each of the sampling devices and analyzed for the presence of SARS-CoV-2. Aerosol dispersion was also evaluated in healthy subjects using non-invasive respiratory support. For these subjects, measurements were collected inside a chamber with a particle counter and a bioaerosol sensor while using high-flow nasal cannula and then during non-invasive ventilation. 31 subjects with a positive PCR test were included and 56 aerosol samples were collected. The majority of subjects were receiving non-invasive respiratory support with a high-flow nasal cannula. 14 subjects had a positive saliva sample and had received a positive PCR result more recently than those with negative saliva results. There were no significant differences between the onset of symptoms and aerosol collection in those with positive and negative saliva samples. Of the 56 aerosol samples, only 4 were positive for SARS-CoV-2, and the positive samples were all collected from the scavenger mask. This figure shows the distribution of aerosol concentration measured in healthy subjects during high-flow nasal cannula and non-invasive ventilation with the devices off and with them turned on. Figures A and B are measurements from the particle counter. The shaded boxes represent aerosol concentration with the device on, and the non-shaded box is with it off. And you can see here that there were not major differences in aerosol concentration with the device off or on. Figures C and D are the concentrations measured using the bioaerosol sensor, and again, there were no real differences between aerosol concentrations when the non-invasive devices were on or off. The results from this study suggest that use of non-invasive respiratory devices such as high-flow nasal cannula and non-invasive ventilation does not increase aerosol dispersion, and these devices should continue to be considered for treating patients with COVID-19. Given the low number of positive aerosol samples, the results also suggest that the high air exchange rates and air filtration used in hospital rooms is effective at reducing aerosol concentrations. Some of the limitations for this study are that the sample size was small and some subjects with COVID-19 were not using non-invasive respiratory support. Mitigation procedures such as a minimum of 4 to 6 air exchanges per hour and use of a viral and bacterial filter with non-invasive ventilation may have influenced the results. And the study was conducted prior to the presence of variants such as when Delta and Omicron were predominant. The editorial by J. Lee discussed the differences between aerosol dispersing and aerosol generating procedures. Treatments that provoke cough or sneeze are of concern due to the generation of bioaerosols, as these aerosols have shown to carry pathogens. While non-invasive respiratory support devices do not generate aerosols, the patients could still cough or sneeze while using these devices. Mitigation strategies such as placing a surgical mask over the high-flow cannula, using a dual-M circuit with non-invasive ventilation, and placing a filter over the exhalation port have shown to reduce bioaerosol particle concentrations, and as well as use of appropriate personal protective equipment and adequate ventilation and room air exchanges in the hospital settings. In conclusion, the findings from this study demonstrated limited detection of SARS-CoV-2 in aerosol samples of subjects using non-invasive respiratory support. High-flow nasal cannula and non-invasive ventilation were not associated with increased aerosol dispersion, suggesting that use of non-invasive respiratory support does not increase dispersion of aerosols used in clinical settings. Thank you for your time, and don't forget to follow Respiratory Care on our social media sites to stay up to date with new content.